Hello and welcome to another session of Path to Success. I am Dr. Pramod Matthews, Professor and Head, Department of Oral Pathology, Marbesilis Dental College, Kodamagi. And today's topic that I'll be taking is a small one regarding mucocele. The term mucocele is a derivation from Latin meaning a cystic cavity containing mucus. Now mucoceles are grouped under salivary cyst, and we can broadly classify salivary cyst into two, that is the mucous extravasation cyst and the mucus retention cyst. And when you speak of it clinically, both are termed as mucoceles. So basically they are clinically similar, but histopathologically if you take a biopsy you can see that there is some difference between these two. Now as I already mentioned, they are both termed as mucoceles, and they constitute around 6 to 9% of all salivary gland diseases. And this is one of the most common cystic lesions that you can see among the salivary glands. And if you look at the location, of course it should be seen within the salivary glands, but remember it is seen mostly among the minor salivary glands and very rarely among the major salivary glands. Now let us look a little more in detail regarding the mucous extravasation cyst. Like many other lesions in oral pathology, this is also having several synonyms. Apart from mucocele, it is also known as mucous extravasation phenomenon, mucus escape phenomenon. And these account for around 85 to 90% of all the mucoceles that are seen. And most are considered to be due to trauma and the trauma to the excretory duct and the escape of the mucus into the surrounding connective tissue. Now, if you look at the statistics, you can see that the lower lip accounts for almost half the cases that is seen. Not only the lower lip, the other areas that this can be seen include the buccal mucosa, the floor of the mouth, and the ventral surface of the tongue, also the soft palate. Here we can see a clinical photograph of a mucocele, and you can see it looks like a fluid-filled blister, and the usual location, as I mentioned, is in the lower lip, and the usual cause would be trauma that can cause the eruption of this or the appearance of this mucocele. Extravasation mucoceles are usually uncommon in the upper lip. Less than 5% of cases are usually seen. And if ever you see a salivary gland pathology on the upper lip, you can think more in terms of a salivary gland neoplasm rather than a mucocele. The peak incidence of mucoceles is usually in the second to third decade. And remember that usually it's trauma to the tissues that are going to cause the problem, that is the appearance of mucocele. The size is usually small, it's less than usually 1 centimeter in diameter, but sometimes you can see in the floor of the mouth where they can be increasing in size up to several centimeters in diameter, but they are then called by another name, that is ranula. Once you take a biopsy of the mucocele, what are the features that you see under the microscope? What is the histopathology? Now, if you are taking a biopsy of an early lesion, you can see ill-defined pools of mucus and acute inflammatory cells. If it is a later lesion, you can see a central cavity that is becoming more and more defined, and that is going to be lined by granulation tissue. Later on, there might be progressive fibrosis, and the cyst is then lined by a compressed connective tissue or a granulation tissue. Along with that, you can see a lot of foamy macrophages, and these contain mucin, in which case we call it by another name, mucinophage also. Now these type of cells are also seen in the cystic cavity and are distinctive in fine cell aspirates. Take a look at the photomicrograph. On the left side you can see a lower power, and on the right a little more higher power or a medium power. In the low power photomicrograph you can see fully excised mucocele, and you can see the extravasated mucin in a cavity on one side, and to the other side of the low power you can see the associated minor salivary gland, obviously from where this mucin has spilled over. And again, the medium power, you can see that there are some changes in the salivary glands. There are inflammatory cells seen, and obviously in the cystic cavity you can see epithelioid macrophages also. In the high power photomicrograph, you can see the compressed connective tissue at the periphery. You can see towards the in the cystic area itself, you can see a lot of macrophages, or more correctly you can say mucinophages. And if you look very carefully, you can see that there are no epithelium that is present lining the cystic cavity. So that makes this actually a false cyst or a pseudocyst. How do you treat it? You have to excise the whole thing along with the associated minor salivary glands. Sometimes it might be difficult to excise mucoceles in the tongue because they might be situated deep, in which case some other procedures like cryotherapy and or diathermy could be used to treat it. I've already mentioned that the larger sized extravasation mucocele is called by the name ranula, and the location is very specific. Usually you see it in the floor of the mouth, somewhat towards the lateral side of the floor of the mouth. And why did that name come? That name came because of the fact that the ranula resembles a frog's belly. Now this is not an actual pathological diagnosis, and histologically all the features that you see in the extravasation mucocele you are going to get in the ranula. Here we can see the clinical appearance of a ranula in the floor of the mouth. It is somewhat having the same color as the normal mucosa, so it must be superficial, and this is usually seen due to the rupture of the sublingual gland. And you can notice that this is seen to one side of the floor of the mouth, not in the center. It is seen to one side of the floor of the mouth, and this helps to differentiate it with the epidermoid cyst, which is usually seen in the middle of the floor of the mouth. Now sometimes it is possible that this ranula that is seen in the floor of the mouth, it can dissect through the mylohyoid muscle, and the contents can go into the cervical area, in which case we call it as a plunging ranula. So that has to be differentiated from any other cervical pathology. The plunging ranula has to be differentiated from any other cervical pathology. Now, how to differentiate a ranula from an epidermoid cyst? Here are some pointers. Ranula is usually seen in the lateral to the midline. It is frequently seen as blue in color, and if you exert some pressure, there is no pitting after removal of the pressure. While for the epidermoid cyst, it is usually seen in the center or in the midline of the floor of the mouth. Usually it is yellow in color, and if you exert some sort of pressure, it will retain pitting after removal of pressure. So these are the things that you can use to differentiate it with the ranula with the epidermoid cyst. Now, what is mucus retention cyst? Some other names for mucus retention cyst include mucocele, mucus retention phenomena, salivary, duct cyst. These are actually true cysts. What do you mean by a true cyst? We already know that mucus extravasation cyst is not a true cyst, it's a pseudocyst or a false cyst. True cyst is a cyst that contains epithelial lining. So epithelial will line the cystic cavity. These are rare. Usually these mucus retention cysts are very rare and usually seen in an older age group. Now, what is the etiology? The etiology is not very, or it is uncertain, but it is generally believed that they are due to an intermittent duct obstruction. Now, why do you get this duct obstruction? That could be due to some stone that is blocking the duct, or it could be due to some sort of hardened mucus that is forming as a plug. So it prevents saliva from moving outwards into the oral cavity. Now, if you take a biopsy of this mucus retention cyst, what are the things that we see under the microscope, or what is histopathology? We can notice that there is a cavity, there is a unicystic cavity, and this is lined by modified duct epithelium. And this lining epithelium is usually thin, non-keratinized, stratified squamous, or it could be cuboidal or even columnar type of epithelium. And if you look at this cystic area or the lumen, that can contain a lot of eosinophilic material that is positive for mucin. Here we have a photomicrograph of the mucus retention cyst. Here we can see the cystic cavity. Cystic cavity is lined by the epithelium, and the associated minor salivary glands is also seen. The treatment for this mucus retention cyst is usually conservative surgical excision along with the associated gland. And if major glands are involved, either partial or total removal of the glands is recommended. Let us take a look at the extravasation and the retention type of mucocele once again. If you look at the histopathology, you can see that the extravasation type, there is a rupture of this minor salivary gland duct. So what happens? There will be obviously spillage of the mucin into the surrounding tissues, and there will be compression of this tissues at the periphery, and there will be pooling of this mucus in this surrounding tissue. So obviously you can notice that there is a severance of the duct. This duct is severed, and the etiology is, of course, this is due to a trauma. Remember that the etiology here is due to trauma. There is severance of the duct and spillage of the mucin into the nearby surrounding connective tissue, and thereby you are going to get a cystic cavity filled with mucin, and the periphery is composed of compressed connective tissue, compressed granulation tissue. Okay, and here lots of mucinophages also can be noticed. Coming to the retention type, the histopathology is slightly different. Here you can see that there is actually no severance of the duct as such. The only problem here that happens is there is something, you can notice something here, that could be a small salivary stone that is blocking the passage of the saliva. It could be the stone, or it could be even a hardened mucus that blocks the path of the saliva into the oral cavity. So what happens? There will be pooling of this saliva here within the ductal system itself. So it can enlarge and form a cystic cavity within this ductal epithelium or this ductal area itself. And you can see that this will be lined by the ductal epithelium. So that is why this is a true cyst. This is the periphery is lined by, or the cystic cavity is lined by the ductal epithelium. And histopathologically, you can notice the differences between these two. But remember that clinically both will look somewhat similar. Clinically, we can see that they look like fluid-filled blisters only. But coming to the histopathology only, you can notice the differences of what has actually transpired here. Now some textbooks also describe another type of mucocele apart from the other two that we have just mentioned. That is, this is called as the superficial mucocele. The etiology of this differs, as well as the location also differs from the other two. And if you look at the location that this is seen seen usually just below the oral epithelium, and this can raise a small subepithelial blister. And it is seen most frequently in the region of the palatoglossal fold. But of course, they can also be seen in other intraoral sites. They are multiple and recurrent. It keeps on recurring. And for unknown reasons, it is or they appear to be much more common in women than men. And superficial mucoceles have been reported in patients with intraoral lichen planus as well as graft versus host disease. Now, superficial mucoceles are more common than is generally appreciated, and they rupture very easily to form shallow ulcers. And these ulcers heal rapidly. So there may be little to see clinically, and that is why you might miss it out most of the time. And because they form subepithelial blisters, these lesions are sometimes confused with mucocutaneous vesiculating disorders like
mucous membrane pemphigoid, and occasionally pemphigus vulgaris, both clinically as well as microscopically. Etiology for superficial mucocele include mucosal inflammation, salivary gland hyperfunction, as well as salivary composition of the minor glands. And it is not just trauma that is responsible for this superficial mucosal formation. And it has been seen that lichen planus, drug reactions, chronic graft versus host disease can sort of trigger its formation. And these transient vesicles are also a complication of head and neck radiotherapy for oral and oropharyngeal squamous cell carcinoma.
This is a clinical photograph showing the superficial mucocele. You can notice two superficial mucoceles on the hard palate. Remember that clinically it might be difficult to really diagnose the superficial mucocele because they have a tendency to rupture earlier and only ulcers might be seen. So careful intraoral as well as the histopathological diagnosis or examination should be done for prompt diagnosis.
For the treatment, usually no treatment need to be done unless it is going to cause some sort of continuous irritation, because most are going to resolve spontaneously. Now, since this disease is rare and chances of misdiagnosis is there, you have to go for a careful intraoral and histopathological examination and come to a prompt or the correct diagnosis. The images taken for this PowerPoint are from various websites, and I am happy to acknowledge all of them. And these are some of my textbook references.
This concludes my presentation on mucoceles. I thank Dr. Sunles, Professor and Head, Department of Oral Pathology, Pushpagiri College of Dental Sciences, for inviting me to contribute to the Path to Success initiative. And I also thank all of you for a very patient hearing. Thank you all.